now.
Hello, good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on PPH management then and now. Doctor, at Hetero, we market products in several therapy areas like in gynecology, dermatology, gastroenterology, pulmonology, ortho, etc. With a very strong R&D background, we try to develop products keeping patient benefit in mind. Our endeavor always is to improve patient compliance and ultimately hope for a better clinical outcome. Doctors, we have developed NSAID patches, reostomin patches for patient compliance, improving patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Frenza. Apart from oral tablets like Dadropal and Mylotin, we market products for vaginal health like Feminora and Pelitra. Recently, we have introduced a vaginal film under the brand name Cellora. It's a lactic acid film to maintain the vaginal pH. We have also introduced Carbetocin under brand name Carbetocin-A for PPH. PPH we know is a dangerous condition, potentially dangerous condition, and all of us hope not to see a PPH patient anytime. PPH management itself has undergone a lot of change, and to speak more about PPH management then and now, we have got Dr. Lavanya with us today. Welcome, madam. Welcome to this webinar. Dr. Lavanya has Dr. Lavanya is a gynecologist and obstetrician, conducted more than 1,500 deliveries, 1,000 cesarean sections, abdominal and vaginal hysterectomies. Madam has managed various emergencies like eclampsia, PPH, abortion, bleeding, obstetric shocks, just to name a few. Doctor has attended several club meetings and conducted awareness campaigns. Madam is trained in sonography. So over to you, Dr. Lavanya, for your presentation on PPH management then and now. Welcome, Madam, once again.
Good evening, sir, and good evening, one and all. Today, we are going to discuss regarding Carbetocin. So, what is Carbetocin? How smarter it is, and how superior and safer choice in PPH management. So today we'll discuss this drug in the table of contents like the PPH, its current scenario, the risk factors and the consequences of postpartum hemorrhage and the prevention of postpartum hemorrhage, and the room temperature stable Carbetocin, its overview and the clinical evidence we are going to present. And finally, we'll give a summary, that is a keynotes. So coming to PPH. So what is PPH? So if you take postpartum hemorrhage, if you take a quantitative definition, it is a blood loss of something more than 500 ml. But coming as a clinician, we would like to see a clinical definition that is nothing but any amount of blood loss after the birth of the baby. So from or into the genital tract following the birth of the baby, which will affect the general condition of the patient till the end of puerperium. So any amount of blood loss after the birth or till the end of the puerperium is considered as a PPH. So PPH could be a primary or secondary. That is, a primary postpartum hemorrhage is something which is occurring within 24 hours after delivery, and secondary is 24 hours until the end of the puerperium. And primary can be further divided into two parts, that is third stage hemorrhage, that is just exactly after the baby birth, before the expulsion of the placenta. And a true PPH is generally what we are going to deal, that is after the expulsion of the placenta within 24 hours, and most of the cases occur within the first 2 hours. So the PPH current scenario is postpartum hemorrhage. It's an unfortunate yet common cause of maternal mortality, accounting for about 35% of all maternal deaths. And the maternal mortality ratio in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. See, you can see a lot of difference between a developing and developed countries. So, and the global PPH incidence, if you see, it is 14 million women suffer from PPH, and the incidence of PPH is reported to be 2 to 4% after vaginal delivery, and it is on the higher side, which is 6% after cesarean section. So PPH incidence in India, if you see, 38% of the maternal deaths are due to PPH, and out of the 25.7% of the global deaths takes place in India. So we constitute almost like 1/4 part of the global deaths. And most of these are attributed to PPH, and India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. So you can think how it is on the higher side, whether it is cesarean section or vaginal deliveries. Cesarean sections have an increasing incidence of severe PPH when compared to vaginal delivery, which is on the lower incidence. So risk factors, who are at risk of PPH, and what are the consequences of PPH? So PPH can be due to 4 T's we generally discuss. That is the tone of the uterus, the tissue factors, the traumatic factor, and the thrombin factors. So if you take the tone, so what we are going to discuss today, carbetocin, is mostly, it's 100% almost for the cases of uterine atony, that is inability of the uterus to contract back or retract back, which may lead to continuous bleeding from the uterine cavity and lead to maternal mortality. And thrombin, which is coagulopathies and failure in the clotting mechanism. Traumatic PPH can be due to the injury to the birth canal, rupture of the uterus, or any lacerations of the vagina. And tissue factors, that is retention of placenta or placental bits or any abnormal placentations. So coming to atonic PPH, which is the most common cause of PPH, and uterine atony includes almost like 70% of the cases of PPH are due to uterine atony. And initial treatment of PPH is usually directed towards the uterine tone, then thinking of other factors. So what are generally the risk factors for uterine atony? So it could be due to any factor which leads to overdistension of the uterus. It could be due to multiple pregnancy. It could be due to fetal macrosomia, polyhydramnios, any chances of retained placental bits due to abnormal placentations, any episiotomy, depth of wounds, prolonged third stage of labor for augmentation of labor. In cases of preeclampsias, previous history of PPH, there is always a risk of PPH in the next pregnancies, and use of anesthesia drugs for induction as well as for labor. So induction of labor overall increases the risk of PPH. Is labor-inducing drugs will have a direct effect on the uterine muscle or act as a fatigue factor on the myometrial muscle, leading to postpartum atony and PPH. So the cumulative effect of the drug used for labor induction on the uterine muscle could cause PPH. So apart from causing mortality, can PPH lead to other morbidities? Yes. What are those? So finally, because of PPH, patient may land in postpartum depression, the anterior pituitary ischemia with delay or failure of lactation, that is nothing but failure of lactation, that is Sheehan syndrome. Continuous blood loss, patient will land up in anemia, fatigue, requirement of multiple blood transfusion leading to dilutional coagulopathies, and cardiac overload with myocardial ischemia. Finally, it can lead to patient death. So in the absence of an identifiable risk factors, PPH prophylaxis is the best way to go ahead. That is, PPH prophylaxis is recommended for all women in the immediate postpartum period to prevent PPH. Due to the uncertainty of PPH, the healthcare provider must be always prepared to treat it at every delivery. So the uterotonic is administered before the delivery of the placenta, and the prevention of PPH. Yes, is it possible to prevent PPH? Yes. First of all, we need few measures for the prevention of PPH, which should start in the antenatal period of the female. That is, in the antenatal period, try to correct the anemia, identify the high-risk factors like previous history of PPH or polyhydramnios or a twin or multiple pregnancy. And patients should have a regular antenatal checkups and appropriate place for delivery. So plan it as an institutional delivery instead of home delivery. And intrapartum, the active management of third stage of labor, we are going to discuss. And drugs like misoprostol sublingual, intramyometrial prostaglandins in case of cesarean sections, or prophylactic carbetocin. And in the postpartum period, uterine massage and the drugs like uterotonics. And fourth stage monitoring is always required almost in all the cases, especially in high-risk cases. So the Ministry of Health and Family Welfare, Government of India, efforts to reduce the maternal mortality. What they have done. So first of all, correction of anemia, effective management of high-risk factors with the Lakshya initiative, which is active management of third stage of labor with the maternal and newborn health kits, a dedicated obstetric high dependency units. So what are the practical problems in preventing PPH? Yes, the home deliveries, the delay in decision, delay in receiving the care, delay in reaching the care from a substandard low-level hospital to a tertiary care center. So PPH is almost responsible in 50% of the cases, it is due to the substandard care. Now coming to practice of prophylaxis of PPH, what shall we do as a prophylactic measure of PPH? Try to improve the health status of the mother, maintaining her hemoglobin at a level of at least 11 gram percentage. Identify high-risk women, plan for an institutional delivery, and strict vigilance of all women in the third stage of labor. And practice active management of third stage of labor in all, and try to examine the afterbirths. That is, it should be a routine. Examine for the missing cotyledons, examine for any missing membranes. The afterbirths should be examined in toto, and explore any uterovaginal canal following a difficult instrumental or destructive delivery. So what is this active management of third stage of labor? So third stage of labor could be managed with active management, which we call as a physiological management. That is nothing but it can speed up the delivery of the placenta and lower the risk of heavy bleeding after birth. So a large WHO directed multi-centered clinical trial has highlighted the use of Uterotonic as the most important step of active management of third stage labor. It contains the 3 steps. That is, first major step is injection of a uterotonic agent for the contraction of the uterus, and delay the clamping of the cord for at least 1 to 3 minutes, and perform only controlled contraction only if it is required, and assess the uterine tone immediately to ensure that the uterus is well contracted. How important is the stability of a uterotonic in PPH prevention? So, use of poor quality uterotonics during the third stage of labor can be less effective at preventing PPH. So what it could lead to? So in the women, it lead to hemodynamic instability, organ failure that can ultimately lead to the death of the women. Risks associated with blood transfusions. Finally, patient may land up with hysterectomies, Sheehan syndrome, and intrauterine adhesions, that is Asherman syndrome. And on the healthcare system, this is going to cause a higher number of units of oxytocin or additional uterotonics, admission to ICU, transfer to a high level of healthcare facility, and need for surgical interventions, blood transfusions, a longer time for the patient to get admitted, that is longer hospital stay. So coming to PPH treatment. So in spite of this active management of third stage of labor, some women may still require treatment for PPH. So when no preventive agents are available or a failure of prophylactic use of uterotonic drugs, so there are other approaches to treatment of PPH. So what we have is uterotonics, that is oxytocin, misoprostol, injectable prostaglandins, and the newer molecule, that is carbetocin. And the prothrombotics like tranexamic acids can be used, uterine tamponade, and finally patient may land up in surgery, leading to cesarean hysterectomy or a post-normal delivery vaginal hysterectomy. So what are the challenges with the current therapies in PPH management? We have many drugs for the current therapy, that is oxytocin. We are going to deal each independently. Now, oxytocin it needs an appropriate training to the clinical staff, and regular patient monitoring is required. It has a shorter half-life, and it needs another uterotonic agent to be added with oxytocin. If you see oral misoprostol, there is a higher risk of severe PPH, increased need for additional uterotonics, greater incidence of nausea, vomiting, diarrhea, and shivering. Patient may run with chills. So methyl ergometrin significantly increased nausea and vomiting. When it comes to Syntometrine, significantly increased risk of elevated blood pressures, nausea, and vomiting. So the WHO recommendations on the use of carbetocin. So nowadays, WHO recommends use of effective uterotonic for the prevention of PPH during the third stage of labor for all births. To effectively prevent PPH, only one uterotonic should be used. So instead of using one uterotonic followed by using multiple uterotonics to increase the contraction of uterus, it is better to use a single drug. So what are the uterotonics to be used? What we use the oxytocin, carbetocin, misoprostol, ergometrin, methyl ergometrin, oxytocin with methogen combinations. So why we have the need to develop carbetocin when oxytocin is already available in the market? So the rationale for the development of carbetocin in a new heat stable formulation. So carbetocin is available in a room temperature stable formulation and in a convenient vial presentation. So the differences, if we see, oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. So in a country like India or any developing countries, where the if you see have studies of 64 countries when it was done, almost 22% of the countries don't have a refrigerator at the root level. So it is very difficult for oxytocin from the point of production to the point of administration. That is, from the point of manufacture, it has to be transported, it has to reach the center where it is to be utilized, and it has to be administered to the patient. This gap is not maintaining this cold chain temperature, because oxytocin is need to be maintained in a temperature of 2 to 8 degrees centigrade. We don't have a heat stable formulation of oxytocin is currently. So resource poor countries do not always have this cold chain transport, as I told prior, and the storage capability is also worrisome. So if you see the carbetocin, it is stable at room temperature. It has a shelf life of 24 months almost at 30 degrees centigrade and 75% of humidity. See the difference. So a country with even 40 degrees centigrade, it can be stored for a period of 6 months. It is extreme temperature of even 60 degrees centigrade, carbetocin can be used for 1 month. So it avoids the need for cold chain storage and logistics, and is provided in the vial form, which is very safe and convenient. So coming to carbetocin overview. So carbetocin, a next generation drug for PPH management. How carbetocin was prepared? It's almost like a sister of oxytocin to say. So it was a synthetic long-acting analog of oxytocin. Therapeutic indication, the only indication where carbetocin is used is prevention of postpartum hemorrhage due to uterine atony. And it is never used in the augmentation of labor or labor progress. So posology and administration. So 1 vial contains 100 micrograms of carbetocin in 1 ml solution for injection. So thus carbetocin was created by making several modifications to the oxytocin structures, which will prolong the half-life by reducing the enzymatic degradation. So how does carbetocin is going to act? Its mechanism of action, that is receptor binding, triggers the activation of phospholipase C, the generation of second messengers, inositol triphosphate and diacylglycerol. These will induce the release of free calcium from the intracellular stores, and binding of calcium to calmodulin stimulates the uterine smooth muscle contractions by activation of myosin light chain kinase. A single IV dose of carbetocin 100 micrograms administered after the delivery of the baby is sufficient to maintain an adequate uterine contraction, preventing uterine atony and excessive bleeding, with efficacy comparable to hours of oxytocin infusion. See the benefits. It reduces the need for additional uterotonic agents. It has a longer half-life. No cold storage is required. Similar efficacy and a good tolerability and similar onset of action. So when you compare carbetocin and oxytocin, so by IV and IM administration, see, you can see the duration of action. Though the onset of action is almost the same in both the drugs, the duration of action after oxytocin is hardly 30 minutes following an IM. And carbetocin, you can see IV administration is lasts for almost an hour, and IM administration is almost like 2 hours. Because the half-life of oxytocin, if you see, it's hardly 3 to 5 minutes, and the half-life of carbetocin is 40 minutes. So a single IV injection of carbetocin achieves uterine activity within 2 minutes and lasts approximately an hour. Carbetocin can increase the rate and force of spontaneous uterine contractions. So what are the benefits of heat-stable carbetocin over oxytocin? So oxytocin it displays a high structural similarity to vasopressin, which is a hormone involved in the regulation of water reabsorption. So this water retention in the body can lead to disturbances in the sodium levels, and oxytocin has antidiuretic effects, and IV infusion may cause water intoxication, an acute form of hyponatremia. So water intoxication has reported in women treated with oxytocin for PPH, induction or augmentation of labor and abortion. So carbetocin is 24-fold less potent than oxytocin at the vasopressin V2 receptor, reducing the risk of hyponatremia. And to date, no case of hyponatremia have been reported in the literature for carbetocin. So we are going to prove with the clinical evidence. So any drug to be proven, it has to have its own clinical evidence. So we will discuss the clinical evidence in the form of efficacy and safety of carbetocin versus oxytocin, the WHO champion trial, and need for other uterotonic agents when oxytocin and carbetocin are used, single dose carbetocin versus continuous infusion of oxytocin, efficacy and safety of carbetocin Syntometrine. So we'll go in detail one by one. So now let us start with how carbetocin is non-inferior to oxytocin. So WHO champion trial, that is a carbetocin hemorrhage prevention trial, which is the largest clinical trial in the prevention of PPH. This trial was conducted by the WHO Department of Reproductive Health and Research. The study design was taken as a non-inferior double-blind randomized trial. The objective is to compare the effectiveness and safety of this investigational heat-stable carbetocin to the oxytocin in the prevention of PPH after vaginal birth. So around 30,000 women were enrolled in this study across 10 countries, including India. The primary outcomes were seen in the form of the proportion of the women with a blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of the women with a blood loss of at least 1000 ml. So this carbetocin non-inferior to oxytocin trial has proved this non-inferiority is established how the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. That is, its efficacy is almost like 14.5% with carbetocin and 14.4% with oxytocin. So the use of additional uterotonic agents are the interventions to stop bleeding, and the adverse effects did not differ significantly between the two groups. If you see the adverse effects, any unanticipated adverse effects, it's almost the same between carbetocin and oxytocin. So the final conclusion came out to be as carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So another study with carbetocin decreases the need for uterotonics versus oxytocin. This study design, which was a meta-analysis with the 5 trials, around 617 patients were enrolled in carbetocin group and 597 in an oxytocin group following C-section deliveries. They have studied this. The primary outcome is the need for additional uterotonic was studied. So the results came out to be as 28% of patients treated with carbetocin versus 51% of oxytocin treated with additional. So only 28% of the patients treated with carbetocin required an additional uterotonic when compared to 50%. It's almost double with oxytocin. And the pooled incidence of blood transfusion was only 2% with carbetocin. Almost it's 5% with oxytocin. This is also like almost double. So patients treated with carbetocin had less need for additional uterotonics compared to those treated with oxytocin. Another trial where a single dose carbetocin versus a continuous infusion of oxytocin was made. The hemodynamic effects of oxytocin and carbetocin was compared and their efficacy was assessed with additional uterotonics. So it is a prospective study, a case control study, around 1 or 2 patients, all were undergoing an elective cesarean section and were at risk for PPH. Carbetocin group received a bolus of 100 micrograms of IV at delivery, and the oxytocin group received 20 units of oxytocin in 0.9% of 1000 ml solution at delivery. So the early hemodynamic effects were assessed as an impact on the blood pressure, need for additional uterotonics, blood loss, and drop in hemoglobin. Along with additionally the blood pressure, the uterine tone and the uterine position was monitored at 2 hours, 12 hours, and 24 hours. So the results came out to be as, and carbetocin and oxytocin both have a hypotensive effect, but the women treated with oxytocin showed a greater reductions in their blood pressures. And significantly more women treated with oxytocin needed an additional uterotonic agents compared to those treated with carbetocin. And patients treated with carbetocin showed a better uterine contractions. The uterus was well contracted at 2 hours, 12 hours, and 24 hours when it is compared with oxytocin. We can see the chart. That is, a single injection of carbetocin was found to be more effective than a continuous infusion of oxytocin in preventing PPH. Now, a randomized control trial comparing carbetocin versus oxytocin was done. when 1210 patients were taken, and at least one risk factor for PPH was identified with them, and single IV bolus of 100 micrograms of carbetocin or oxytocin 20 units over 6 hours infusion was given. The primary outcome seen as PPH of more than and the less blood loss in carbetocin group compared to oxytocin group, and less number of patients treated with carbetocin needed additional uterotonics compared to those treated with oxytocin. So management with carbetocin is associated with greater reduction for PPH compared to oxytocin. Now, how carbetocin a good alternative in PPH prevention in high risk? So, a study design, which is a prospective single-centered randomized double-blind controlled study, was done. Patients enrolled around 314 in carbetocin group and treated in an oxytocin group. The primary outcomes, again, the blood loss of at least 500 ml within 24 hours postpartum was seen. So when the primary outcomes and the secondary outcomes were seen, like blood loss of 2 hours, after 2 hours, after 2 to 24 hours, need for manual removal of placenta, uterine bleeding. So after so many outcomes, they came out to be with the conclusion that carbetocin significantly decreases the risk of manual removal of placenta, especially in women with induced or augmented labor. And carbetocin has 83.1% probability of being the best agent to reduce the PPH of more than 500 ml after vaginal delivery. The advantage of its application at the end of third stage of labor was that there is a decreased need for uterine massage or need for other uterotonics, and it narrowed the hemoglobin fall. So comparison of carbetocin versus oxytocin, need for other interventions was studied. So here carbetocin was given as an IV injection of 100 micrograms, and oxytocin was given as a bolus of 5 units or bolus 5 units followed by 10 international units in 2 hours. The efficacy was measured in terms for need for additional uterotonics. So only 3% of the patients treated with carbetocin required an additional uterotonic treatment when compared to 7% for oxytocin. It's also almost like more than half. So carbetocin was most effective compared to oxytocin 5 units bolus. So compared to oxytocin, prophylactic treatment with carbetocin after an elective C-section reduces the need for additional uterotonics by more than 50%. Efficacy and safety of carbetocin versus Syntometrine. Now, the efficacy and safety of a single intramuscular dose of carbetocin, here intramuscularly they have given the carbetocin, versus Syntometrine in the management of third stage of labor following the vaginal delivery, was assessed in women with a low risk of PPH. Here, 240 women with a high healthy singleton pregnancies were taken. Carbetocin or Syntometrine was administered as a single dose IM injection following vaginal delivery. Assessment was done in the form of a requirement of an additional uterotonic therapy, the incidence of PPH, amount of intrapartum blood loss, and adverse effect profile. So it came out to be there is a significant difference between the mean blood loss in carbetocin group when compared to Syntometrine group, and there is a lesser mean drop of hemoglobin after 24 hours of delivery in carbetocin group when Syntometrine group. Finally, a better hemoglobin on the postpartum day 1 in carbetocin group when compared to Syntometrine group. So there is a reduction in the postpartum blood loss, smaller drop in the hemoglobin levels, and the lesser adverse effects makes the carbetocin more effective than Syntometrine. So when you see the adverse effects of carbetocin versus oxytocin, so gastrointestinal disorder, the general nausea, vomiting, nervous system like headache, leukocytosis, and arrhythmias, palpitations, the fall in the blood pressures and skin rashes. When you see all these, the adverse effects are almost very minimal with carbetocin when compared to oxytocin. So efficacy of carbetocin was checked against conventional uterotonic agents for the prevention of PPH. Carbetocin was compared with oxytocin, Syntometrine, or placebo when given IM after normal vaginal delivery as well as cesarean delivery. Carbetocin is effective compared to other conventional uterotonic agents. That is, statistically, there is a significant reduction in the need for other therapeutic uterotonics compared to oxytocin in cesarean deliveries, and lower risk of PPH, reduced need for uterine massage compared to treated with the oxytocin group following vaginal or C-section delivery, and there is a lower blood loss compared to those treated with Syntometrine. So intramuscular administration of carbetocin at a dose of 100 micrograms is more effective than oxytocin for preventing PPH. Its use is associated with a less blood loss and a better tolerability and profile compared to Syntometrine. So this comparison of carbetocin with oxytocin was done following cesarean deliveries as well as the vaginal deliveries by various studies. So in women who underwent cesarean deliveries, the risk of PPH was lower in the group receiving carbetocin when compared to the group receiving oxytocin. So this comparison studies, carbetocin was found to be efficacious compared to Syntometrine in the management of postpartum hemorrhage. And the efficacy and safety of carbetocin versus Misoprostol plus oxytocin. Yes, one more drug, Misoprostol. They have done studies with the Misoprostol also. The objective is effect of a sublingual Misoprostol plus oxytocin infusion was compared with the intravenous oxytocin for the prevention of PPH in patients with the risk factors during cesarean section. Study population, around 380 people were taken in this study. They received a combined 400 micrograms of sublingual Misoprostol with 20 international units of oxytocin. Few people required IV carbetocin 100 micrograms. So outcomes were studied as uterotonic requirement, other uterotonics, hemoglobin levels, and the estimated blood loss. Finally, the results came out to be as there is no significant difference was observed in the requirement of additional uterotonic in carbetocin versus the other group. And the pre and post-operative hemoglobin and estimated blood loss were also the same. So intravenous carbetocin demonstrated the similar efficacy to a sublingual Misoprostol plus oxytocin infusion for the prevention of PPH. So coming to the guideline recommendations, the guidelines recognize the benefits for carbetocin for preventing uterine atony. So various recommended bodies like WHO, SOGC from Canada, RANSCOG, New Zealand, and FIGO, Germany, Austria, and FCOG from France, all they have included carbetocin in the treatment of PPH or in the third stage of labor. So the key messages I would like to share with you all is postpartum hemorrhage remains a clinically significant cause of maternal complications and death, as it's common and can occur even in women who are not at risk. And it has a major impact on the lives and the health of the affected and their families. And WHO recommends use of carbetocin, an important step in the active management of third stage of labor. And this could reduce the risk of PPH by more than 40%. So carbetocin is a synthetic long-acting analog of oxytocin created by making several modifications in the oxytocin molecule. It is now available as a room temperature stable formulation in a convenient vial presentation. Carbetocin has a similar efficacy and a safety profile as oxytocin. It has significantly reduced the need for other interventions and uterine massage, need for other additional uterotonics. It reduces the blood loss of, to almost less than 500 ml in more women. And the Champion trial inferred that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. And compared with Syntometrine and Misoprostol plus oxytocin, carbetocin demonstrates significantly better hemoglobin levels, and there is a lower risk of hypertension or the fewer adverse events. WHO, FCOG, and many other bodies have recommended the use of carbetocin in the management of PPH. And here we comes, thank you for the makers of carbetocin injection, Carby Act by the Hetero Healthcare, the savior in PPH, Carby Act. It is available as 100 micrograms per ml IV infusion. And thank you.
Thank you so much, madam. Thank you for this presentation. So lovely. We got good insights into PPH and carbetocin. Now, with this, superiority of carbetocin over oxytocin and other uterotonics, and being recognized by bodies like WHO, can we say that carbetocin should be used prophylactically in every delivery rather than keep it as a reserve drug?
No, try to keep it as a reserve drug, because once carbetocin is given, we can't use any other uterotonics beyond that. So
Okay.
because it can be used as a prophylactically in anticipated cases, highly anticipated cases, like there is a previous history of PPH or polyhydramnios where it is a over distension, you are going to expect chances of uterine atony in those cases. So it is better
Patient
to
at
use,
risk.
yes, patient at risk can be given carbetocin as a first drug, but in
All
all the
patients.
other
Yes.
cases, try to give other drugs, because once they fail, we can give carbetocin as a second drug also. But if carbetocin is
Understood.
given as the first drug in a normal, in few cases, we may land up in trouble. So
And another thing, if oxytocin is used in antepartum period,
yeah,
especially in the second trimester, I mean the second stage of
stage of
labor,
labor.
can
Yeah.
we use carbetocin in the third?
Sure, you can use. There
Can
is
use.
nothing.
So this,
So if
yeah,
you have induced labor with oxytocin, augmentation of labor was done with oxytocin, you can after the delivery of
very
the
well you
baby,
could do
you can
carbetocin.
use carbetocin.
And is there something like there are people who have used oxytocin in the second stage, in third stage. Over a period of time, does it so happen that the oxytocin, I mean the uterus doesn't respond to oxytocin, receptors get desensitized or failure, something like that? How common it is?
So we see in few cases where continuously, if you are giving it IV as a
Yeah,
bolus
infusion.
oxytocin, so when people see a PPH case, it's almost like a nightmare. So
Oh yeah,
exactly. So we are almost like we need to call for an extra help. We'll be almost like, especially in the centers where there are no facilities. So it will be like a nightmare because no drugs will be
absolutely.
available to treat. The only drug available will be like almost oxytocin. People will start you doing uterine massage. People will start giving it IV, IM,
Yes,
IV
yes,
infusion.
yes, yes, yes.
It will give hypotensive effects. Again, need to give some other drug. Need to add multiple uterotonics. So over a period
That's
of time,
correct.
it fails to respond to oxytocin.
Oxytocin. And madam, amongst causes for uterine atony, which is the most common cause which can give PPH, like prolonged labor or multiple gestation or use of uh, oxytocin or
So it is
fibroid,
the
which is the common
prolonged third stage of labor, because
prolonged third stage.
especially in government sector, when we
Yeah, yeah,
see,
yeah, yeah,
we will try to, and moreover nowadays governments are putting such a pressure that patient should be delivered by normal route only. So we
yeah.
have to
Correct.
give as much trial as possible. Let the cervix get dilated. We
Oh,
need to
Baba.
give oxytocin drips. The drip gets completed. Again, add one more 5 units of oxytocin in the drip. Try to dilate the uterus, induce the labor. So
As much
we
as
are
you
doing
can,
as
yeah.
much as to. Because of this, third stage of labor almost gets very prolonged if we see in government sectors, because it happens. It happens because
Okay.
there in few sub centers and
Yeah,
PHs, like when we go for a normal delivery, they don't have the facility of cesarean section. So people feel like, in spite of referring the case for a
correct.
cesarean section to a higher center, try to augment the labor as much as possible. And patients in the rural areas, especially in our countries, try to get
Yeah,
preferably delivered by a normal delivery,
yeah,
so
yeah,
that
yeah.
they
And
can
many of
revert
them
back
are home
to
deliveries also
normal.
still.
So
Yeah.
because of this prolonged third stage of labor, where she has delivered already 3 kids, 4 kids, so already 3, 4 deliveries have done. So the uterus will fail to regain its original contractility after the delivery of the baby.
Correct,
So
correct.
in our country, the multiparity and prolonged third stage is more compared to multiple pregnancies like twins or polyhydramnios.
Yeah,
And
yeah, yeah.
retained placenta is also one of the times, because of this uterine
Common cause.
atony. Also sometimes the placenta gets fails to get
Absolutely.
separated. So
Correct.
when placenta gets failed to separate, automatically fails to expel, the uterus can't retract or
Right.
contract back to its original
Correct.
state. So from the cavity, the uterine sinuses is already open. They start pouring blood like a tap.
That's right. Very sad.
Yeah.
And how would you manage a PPH in patients with preeclampsia or in patients with second trimester MTP?
So,
Would it be the same or?
so preeclampsia, obviously, so better is to grow. We'll start with oxytocin, obviously, post delivery.
Yeah,
We
yeah,
try to avoid methergine as usual. Misoprostol can be tried. And abortion also we can try with oxytocin, and we give on the higher number of units. That's it. So
would you place Carbetocin in these patients?
Yes, we can use. There is no issue. We can use.
I suppose one of the major advantages of Carbetocin is no cold chain requirement, at least in
That
our
is
country.
the major. See, in our country, almost in major developing countries, almost there are 22%, around one more study was done where 64 countries were studied. Out of the 64 countries, one of the countries is India, where 22. So without a refrigerator, it is from the first of all, even if we get the drug, we'll try to put it in the fridge. But what is the cold chain transport? How it is maintained from the point of manufacture, the long way it has to receive the center of use. So by that time, so in government sector, where we see people keep loading oxytocins and try to keep them ready, like 10 to 20 oxytocin injections they'll try to, because there are multiple, we get so many number of patients, we have to, so as usual, our staff will be on the lower side. One patient, if 3-4 deliveries are happening, she can't load oxytocin for all the 4 deliveries. So what she will try to do, one by one, she start giving. So already, even if it is maintained throughout the cold chain transport, after it reaches our institute, how it is maintained is also very important.
That is right. And plus, we have got electric failure or electricity failure also.
Electricity is a major factor.
It happens even, places like Bombay, Hyderabad also it happens.
Exactly.
Then, in your practice, suppose, I mean, you don't get good results with Carbetocin. What would you add? I mean, what would you use as second line?
So after Carbetocin, if you have not used anything, we generally put Misoprostol also sublingual.
Correct.
Okay, along with Carbetocin. The best thing is do a uterine massage and do a uterine tamponade. Like try to do a bimanual compression of the uterus. So try to do it physically. So almost like Carbetocin you have given. So it's almost like the drugs are not going to work. Try to arrange for blood, because we don't know how long it will take to get its own tone.
Absolutely, yeah.
So try to keep the blood and blood products ready. Okay, then try to do manual compression of uterus, bimanual compression. Try to keep doing uterine massage, and try to do foot end elevation. So many, because we need multiple persons. So because always PPH is a dead emergency where you need to draw the samples from one point. One should run to blood bank. One should start giving the uterine massage. One should start doing the tamponade, balloon tamponade will keep ready. So if it is not the drugs, then the mechanical methods.
Basically, the physical measures. Mechanical measures.
So after the pharmacy, it is only mechanical and physical methods.
One more question has come up. 1 minute.
Yeah, sure.
Can you use Carbetocin in diabetics or patients with blood glucose issues or hypertensives with blood pressure?
So hypertensives, it is better try to avoid compared to diabetics. You can use. So in asthmatics, in patients with a prior thrombotic events, in patients with hypertension, preeclampsias and severe preeclampsias, try to avoid Carbetocin. In diabetics, it can be given.
Diabetes, it can be given.
It can be given.
Now this question is entirely mine. Now, looking at all these pluses of Carbetocin over Oxytocin and other uterotonics, why is it not gaining that crown position, #1 position?
It's like our country generally sees regarding the economy.
That is it.
That is exactly. So it's the only awareness of the government should be there, not the people. So though it gets practiced, because people get a tension, like if they are using Carbetocin, if it is not going to contract, then what next we can do? So and as usual, the government, because PPH is such a it will be mostly there in the subcenter areas, so substandard hospitals, so where they don't have the option of carbetocin. They have only the option of oxytocin or
Oxytocin.
misoprostol or maximum methylargometrin. So if government is ready to provide carbetocin, surely I am sure in future this is going to be a wonder drug in the prophylaxis of PPH as well as in the treatment. Like as soon as the delivery of the baby is done, better to give, because we have seen how the uterus becomes so hard after giving carbetocin in our personal cases. So when we give carbetocin, almost as a textbook described, the uterus becomes so hard like a cricket ball.
Stony hard. Correct.
So it becomes so hard. So there is no chance of PPH after giving carbetocin. The only thing is it should be made available at all levels of healthcare system.
That is correct.
That is more important.
Thank you, madam.
Yeah.
These were all. If there's anything more, we'll come back to you.
Sure.
Thanks for taking time and this elaborate discussion and question
Thank
answers.
you for giving me this opportunity. I should thank
you
for making me a part of Carbeact. Thank you so much.
Madam. Thank you. Thank you all the doctors for participating, taking time. Thank you very much. That's all from our side, madam. Thank you.